So my question is, since you are all involved in academic training, what are you doing to change the system to educate students and residents in innovation and entrepreneurship?
Well, how do you educate in innovation and entrepreneurship? I mean, ironically, when I was teaching the community pediatric and child advocacy rotation, because it was cutting edge, and I think there's more and more that's coming out on the links around the social determinants and innovative companies that are being founded in this space. There's a lot of work happening in this right now. But I was actually the opposite, because I was worried they were going to go out into real clinical practice, and we weren't even asking a lot of these questions. So I think there's, we were actually, when I was at Stanford, we were doing that. I don't know in terms of some of the other panelists, but I think that part of it is the way that things are set up in terms of requirements. So we actually had a statewide group that was working with all the pediatric training programs across the state of California to be able to bring some of that cutting edge work forward and cutting edge knowledge and clinical practice in working towards health. But I don't know if you have.
Yeah. No, I think it's a great and important point to communicate, because, so I'm also at Stanford, but Stanford has a biodesign program, which is very well known. Paul Yock started that many years ago, and it's flourished. It's now in, I think, 4 different countries that have biodesign centers, essentially bringing physicians together with engineers and sometimes even patent litigation attorneys and patent prosecutor attorneys to form companies around ideas that have been validated based off needs assessment. And I think across the talks today, we heard a lot about need. There's a lot of needs out there that we have a unique position as physicians and at academic institutions in particular to understand where those needs may be. And we do have a unique platform to be able to study that at a technology level and develop those technologies. And so with the residents, with the fellows, with the medical students, it's critical to communicate that. And biodesign is one way to do that to the trainees. We have internal grants within the Stanford Medical School, whether it's the Cardiovascular Institute or whether it's other innovation institutes within the school, to actually sort of solicit proposals between faculty and fellow, faculty and resident, that would actually go forward with some funding to develop some of these ideas. And then you have to have the culture at the institution that would allow a student or a fellow or a resident or a faculty member to actually innovate in an entrepreneurial way. And I think Stanford StartX Med, and those are basically funding mechanisms that Stanford actually is a significant financer of to develop ideas in a sort of an entrepreneurial spirit. So I think those types of things are there. They're maybe not as prevalent as they should be, but I think those are kind of examples of what we need more of.
Yeah, I think that's a really important, great question. As demonstrating, like through democratization of some of this education and skill sets, a lot more people can get involved. So it's not that you have to be a fellowship trained person only to do something, or I have to have 20 years of experience. And that's the thing that we have been championing, where democratization of this knowledge, skill sets, engagement, building community around this, where there are mentors who can guide people into these advanced techniques. But starting off early, starting off where nobody would have thought that a high school kid or a medical student can be engaged in developing an AI solution, and how can they build upon that further. And again, for us locally at Cleveland Clinic, we have our innovations group. There are a lot of other innovation partners, and SOAP does an excellent job, and I'm hopeful that we'll start the Cleveland chapter soon over there. But to me, the prime thing is exposing them, supporting them, educating them, and building a community around this to leverage.
Thank you. I think I'd echo all those thoughts. I think we need an end-to-end solution. So you start off with the medical students, the residents, the fellows, trainees. You create an environment that allows their ideas to surface, create an infrastructure around them. So we have an innovation hub at UW called CoMotion that would actually incubate that idea and take it beyond just get a rapid prototyping, if it's a device or a proof of concept, and then actually give it some feedback early on with people who actually use the device or the technology, and actually give them a system to plug it into. So in our case, it started 4 years ago on a Starbucks napkin. You can Google it, and it started with an idea with a Sharpie on a napkin, and then now we're actually deployed in a handful of hospitals. So, but we actually had an end-to-end solution. The other thing is, in terms of creating that environment, we don't need to reinvent the cookie cutter. You just look to places like who does it really well. MIT does it really well. Georgia Tech does it really well. The innovation hub from Georgia Tech spun out 50 companies last year that got over $1 to $2 million funding, all led by students. So there are places who know how to do this, and we can just reach out and ask them. From a personal point of view, because you asked the question, what am I doing? What are we doing? I'm just trying to trailblaze. It's no one had ever spun out a company from my particular hospital, although they have from the university, and it's just having that leap of faith. Hey, just do it. I'm just an anesthesiologist. I didn't know anything 4 years ago. I didn't know anything about anything outside medicine. I'd never raised money. I haven't done an MBA. I don't know about finance. I don't know how to start a company. I don't know what a C Corp is. I know nothing about software, but I just had an idea. And you just reach out to your community, you network, and then you can build something from an idea if you have the people around you and you're willing to ask for help. So there you go.
Conference is all about networking, and that's what we want to grow. So though we have 40 speakers over 2 days, I think we got so many more requests to be speakers, and we'll accommodate many more next time. So we'll get another question from the back there.
Hi, so I will flip the exact scenario. So we are a startup, we are engineers. We are trying to bring AI to all of you. Problem is you as experts. Some of you have already taken the leap, which is great, but how do we reach out to the rest of it? Because we run cancer data, we have cardiovascular data, we have ortho data all over the world. Problem is you are the experts, you know what to do with it. So flipping it back, how do we reach out to you? Yes, there is SOAP, but we are in Princeton. East Coast is different. It gets worse in Texas, where I used to be. The problem is there are doctors and experts who really want to work. They just don't know how to reach out. And we are startups. We don't know how to reach out to you because we are scared. Like you walk into a hospital and just wait. I can't get my engineers to do that. It's not possible. So, what are your suggestions? Like, how do we bridge this gap?
So the question is, how do startups and innovators, the technology side, bridge the gap and come to the medicine side? So go ahead.
Let me take that, because we have done that work. So if you look at the research work that we did it with a startup called Petrium, which is a spin-off from Carnegie Mellon University, and we have done other work with other companies too. And that was the whole basis of forming what we call the BrainX community, that we build a community, and that's not just of physicians or healthcare people. It's actually a lot of data scientists. It's a lot of scholars from computer science, machine learning, entrepreneurs, or other groups. So it's everybody who's there. So I'm not sure if East Coast has heard enough about social media, but there is something called social media, which is a transformative way of communication these days. And I think we have to leverage that more and more. That's why we leverage LinkedIn. We try to stay away from Twitter because there are certain tweets that we find a little bit tough. So we try to stay out of that. But I think part of also the reason why I presented this review is to give you a landscape of who's doing what. And once you understand that these are the people who have expertise or intent or have interest in this area, I think reaching out to them becomes easier. So now if you're a startup that is looking at a radiology solution, you can look at that and see, okay, who are the physicians who are interested in this? But if you go to them with a malaria solution, they're not interested in that. So that was part of the reason to put that out there so you can connect these dots.
Yeah, I would say I think that's it's a perfect question. I think part of what's happened is there's been a lot of innovation outside of medicine. We used to see this a lot when I ran the Precision Health and Medicine program. And so part of it is just start finding, I think because it's so important, is right now is actually having the real evidence to show that things are effective. And the best way to do that is through partnership. So some universities have actually set up kind of lead institutions, but I think your point of going directly to people who are working on this from the literature is great, and then events like this.
we'll go with the next question from the front here.
So I'm a clinic manager, and this question's more for Dr. Lowe here. So back to the opioid crisis and what we can do. I love your program. I was kind of doing some research on it, the MD metrics. Is that, and I know you work more hospital-based medicine, but would that be beneficial for my providers in the clinic? And how do I help my providers not expedite their burnout by the prescribing of opioids within clinic? I'm finding a lot of my providers are almost trigger shy to prescribe. It's very stressful on our providers. So I'm just looking for advice on how to go about helping the providers through that.
Can you repeat the question?
I'm trying to paraphrase the question. So you work in a clinic, you have a bunch of providers, you're trying to rationalize opioid prescribing.
Trying to help them through, like when, I mean, they come to me and ask, when should I prescribe an opioid, which is totally outside my lane, but their confidence is just so much lower because of the amount of prescription. Yeah, the consequences and the laws that are around it. We're from Nebraska, so there's been quite a few laws that have been implemented recently. So just how to bridge that gap, and then is your program available for outpatient use?
Yes. So there's two parts of it. MD metrics is one side. We can sit on top of any structured database that comes from any facility. So if you're collecting structured data on provider prescribing habits, we can totally work with that. The best work that's been coming out of this is actually from Emory, where they actually looked at their physician prescribing habits and actually gave them charts of MME equivalents of what they're prescribing, and they mapped it against ICD-10 codes for patients, and they did it for their surgeons. So you'd see a 3 or 4x variance in how much opiates they're prescribing for a certain operation. And number one is exposing it, right? So you start at the source, and then also from their outpatient and their primary care docs, they're giving them all cards and showing them, hey, this is how much opiate you're prescribing relative to your peers, because we have to get a handle on this. So, but I can help connect you. We can talk offline. I can help connect you to those folks because they're doing some awesome work. The other place is Intermountain's doing some really awesome work in this area. They gave an app. So actually it's called Opiate RX. So it's a plug for Intermountain. They collected real world data from patients having surgery, and they via an app for a year, and they just gave it back to the world. So now you can download this app. It's called Opiate RX, and you can say, hey, you're coming in for a total thyroid next week. The last 251 patients needed 6 doses of oxycodone, so I'm going to give you 6 rather than 30 or 90. So they actually use real-world data to rationalize their prescribing. They reduced their outpatient prescription by 12.5 million pills of oxycodone last year in 2019, and their opioid overdose rate coming to the ERs dropped by 13%. So yes, it saves lives.
Okay, next question.
If I may just add real quick, because I'm another gas man. So it's not just about opioid reduction. It's also about, okay, you don't give them opioid, you still might have pain, right? So it's about those multimodal solutions, and that's another thing that we are looking at, increasing utilization of those multimodal solutions. Now, they might be pain blocks, they might be giving like some alternate medications, just like Dan talked about ketorolac and everything. So we are also looking at those solutions and measuring those solutions, whether the utilization of those are increasing at the same time or not. Because otherwise, how do you make it effective for the patient at the end? You can just stop giving them opioid, but that's not the solution for the patient. They still need treatment of the pain.
Hi, I'm Chance. I'm the president of the Canadian Association of Physician Innovators and Entrepreneurs. And my question is to you, Dr. Dan Lowe. We've talked today a little bit about EMRs that are more innovative, focus more on user experience or have better security. But, I'd say the major barrier in getting to better EMRs is actually getting the data out of the old EMRs into the newer EMRs. So you said your company focuses on data mining, and I'm wondering what are some of the major technological, commercial, and healthcare challenges that you have when trying to get data out of an EMR?
So basically the question is about how to retrieve data from old EMRs to new EMRs when you're transitioning, or interoperability, I think.
Yeah.
So hospitals are graded in their technology maturity on a HIM scale. It goes from 1 to 7. If you're 1, you're still carving in stone in tablets, and if you're 7, you're at the top of the pile. There's about 2% of hospitals have reached HIM 7 maturity, and about 25% are at 6. And 6 seems to be a threshold, and more reaching that threshold. What it means is they have an electronic record, so they're moving off paper. And you think, well, hasn't everyone moved off paper? Not entirely. Some hospitals are still on paper for their anesthesia systems, for example. Once you have that electronic data, so you have an EMR, what do you do with the data except generate a bill? That's the next question. What are you going to do with it? Now, the hospitals that are savvy and the systems are savvy will warehouse that data. You wouldn't believe it, but 70% of hospitals that buy an EMR don't bother warehousing the data. It just goes to but that is the most valuable asset you have that you're generating every day, and people need to understand that's gold. Because if you know how, if you number one warehouse it, and then number two, once you warehouse it, start doing systematic analytics on it, because that's where you're going to improve your operations, that's where you're going to improve your flow, that's where you're going to improve your outcomes and your finance and your bottom line and just everything around it. So the hospitals that figure that out are going to come out top when this kind of value-based care storm actually hits us. So.
That was the point I was going to make in terms of value-based care. I think that's one of the things that, this is on a different hat that I'm wearing, but part of the big challenge is getting actionable information. So as more of the contracts get tied to risk for outcomes, there's a lot of misunderstanding and opacity right now, even in terms of what value means. And so I think that systems, there are a lot of pressures right now to do that kind of work.
Yeah, and I think there's two parts to this battle, right? So getting the data into a usable format is critical. But just getting access to the data doesn't mean you know how to ask the right questions, and I think that was brought up earlier. The problem is, half of our medical decisions are not evidence-based. And the reason for that is not because physicians may not, it's a combination. They may not know what the latest guidelines are, but they may not even know that this patient is eligible for that guideline. And so you need automated systems to add intelligence to the data to surface things in an automated way as well. And I think that's kind of the other half of the battle. And you can add quality-based metrics, value-based metrics to that data set in terms of those algorithms in order to make it truly practice-changing.
Hi, everyone. I wanted to ask a follow-up question to Arlen's question about the role of innovation and the space for innovation within medical education. So I'm one of the Canadians in the room. I just graduated from medical school. And while I have a lot of respect for all of the initiatives just shared on stage about those that exist in Stanford and MIT, my question is, what about the rest of the world? And what about the realities of a medical student going through medical school? So some real examples I have are there are students in my medical school that are afraid to even share that they have an interest in entrepreneurship, and they do this in silence because they're afraid of being ostracized as, oh, you don't care about medicine, you're not motivated, you care about money. Or, I've had personal experiences of trying to request time off to go to speak to politicians or go to WHO meetings or come to the Valley to learn about technology, and the response is very much, you're distracted and that's not important. And I was just speaking to a medical student outside who has, done work in the digital health space, and he was at one point interested in a surgical specialty, and met with a program director that said, well, to be perfectly honest, if I see that on your CV, it's a bit of a red flag. We're looking for people who can publish, who have really great clinical grades, and there's so many people for us to choose from, and so this is the reality of some of the challenges that exist when you're a medical student, curious about all of the things we've talked about and our place in designing the healthcare system or gaps that exist. And it feels almost as if it's not a choice between whether one shall innovate or not. It almost feels like it's a choice between, do I remain curious, do I ask questions, do I be creative, or do I keep my mouth shut and ensure that I can actually match and have a future in a residency that I hope for?
The question is how medical students come out and tell that they get eaten. It used to happen when in academic medicine, we used to show interest for private practice. Same thing will happen because most of the professors, they promote you to do more academic practice. But yeah, go ahead.
Well, I mean, right now we need innovation more than ever. I mean, particularly if you look at the data in the US, we have seen a drop in life expectancy. So we spend more on healthcare and compared to peer countries, and we have worse health outcomes. Canada does better than us. But I think part of it is, and I mean, even in my own career path, and I'm sure everyone up here on stage had some of those things. I never followed a traditional path. I did a joint degree from the very beginning. So I think that and that's becoming more and more the norm. And even doing a lot of physician leadership. I'm speaking at our Physician Leadership Academy coming up. I was, doing a lot with mentoring students. So I think part of it is finding, and this is, I mean, again, I think it really goes back to the community of thinking outside the box, of thinking about different ways to solve problems and starting to create that community. Part of it, I would advise a student going forward, if you're not already in that type of program, to try and specifically seek programs like that out, because there are a number of programs that actually, obviously Stanford, UCSF is another terrific example, Harvard, but there are many programs that actually do foster that. So the communities and online communities. I don't know if you guys have other thoughts.
Okay, I'll take it from online communities. So it's interesting you say you're from Canada. There is a society for AI for medical students that is from Canada. It's actually University of Toronto. A couple of medical students got together and they did that. So I don't think the standard orthodox pathways are barriers. So I'm a doctor, right? And I'm a fake computer scientist. So I did all my training online. Now there are a lot of like fake data scientists who presume to be like doctors. So I'm putting it out there. Like, yes, all my training is online and all. But that is pretty disruptive, right? So I can write machine learning and AI algorithms, but all that training was online and through collaboration and other work. So now the knowledge landscape and the skill sets, that whole landscape has changed. It's gotten democratized, as I demonstrated. The fear from some of us, the senior people, or getting to be senior people like us, is that is pretty disruptive. You guys are more agile, you guys are smarter, you guys are faster, right? So some of that is fear. But some of what they say is true orthodox and is of valid importance. That if you're a medical student, you want to gain that important medical knowledge first, and not just get distracted into a lot of other things. So I think it's a fine balance between the two. But between the social media, between the communities, between the support groups that exist over, there's so much to be done and so much that you can leverage.
First, thank you for the question. I'm sitting here listening, and I want to acknowledge how hard it is. If you're going to go into this space and innovate, by the very nature, innovation is disruptive. You end up pissing some people off. I mean, that's just how it is. Okay, you're disrupting the status quo. So the people who are entrenched will feel some people will just feel threatened. Okay. Given that you want to be in that space, that means that you want to be changing healthcare. Now, the currency for changing healthcare as a physician, you actually want to be an agent of change, right? I have to say that carefully, agent of change, right? So, and the currency for that is being a good clinician, right? Because if you went through med school and then you dropped out of residency 3 months in, and then you went to create some innovation, it'll be really hard to sell that back into healthcare, because they'll look at you and go, well, so you're a failed doctor, right? So go be a doctor, go do, just learn your craft, and then practically, first 4 years, do 80% learn doctoring, 20% indulge, right? Once you've kind of sussed it out, go to a 60-40 ratio, and then go to a 50-50 ratio, go change the world, go rock it, okay? That's, all right.
I'm just gonna challenge that, present a different viewpoint. Just go do what your heart tells you to do. Okay, it's not about like 5 years, 10 years. So I train a lot of fellows. I'm a program director for our critical care fellowship, and the standard education or standard thing to them was, well, why don't you become a good clinician for the first 4 or 5 years, then think about education pathway, administrative, becoming a medical director and everything. I tell them, no, you guys are very smart. Believe in yourself, be a good doctor, but if your heart tells you that this is the right thing to do, pursue that from the very beginning.
I would would say my last piece of advice, I give a lot of advice, and whenever I say just always take it with a grain of salt, because everyone talks from their perspective. I think I did probably a mix between those, where I practiced for a number of years, I taught, so I got to be on faculty, part of the system. I do think there's a lot in terms of having practice and having that under your belt, but there are many different paths to get there.
So I think we've talked about general personal pathways, but you talked about access, right? How does the rest of the world learn about innovation and get involved? So, Stanford's putting their entire medical school curriculum online. So Digital Medic is going to be free for the world. I think it's live. It might be. I'll have to talk to Shakti about that. But adding in entrepreneurship courses is actually, the Stanford medical program is ridiculously focused on entrepreneurship. A lot of the med students won't go to residency, right? They'll start companies. But I think that there's a component of that. There's a thread of that. It's probably not heavy enough for what you're asking for, but it's an interesting idea, actually, to blend biodesign and the digital medical school curriculum into something that's a more innovation-focused track.
And I think you are doing the right thing, coming to this kind of conference to hear from these people.
You're so lucky to have these 4 folks in front of you, Arlen. All kinds of folks know you are both future leaders. Do what you need to do.
Thank you.
Okay, next question.
So my question is to our two anesthesiologists. Since we know that pain is the 5th vital sign, that's what we keep getting told as part of our Press Ganey surveys, whatnot. By any chance, has anybody had the chance to come up with an algorithm that can actually measure the level of pain that the patient is telling us to have at that moment, and that may help us guide our management a little better?
The question is, can you help me debunk the myth that pain is the 5th vital sign, right?
Yes.
Okay, so a couple of years ago, we didn't know this, but we were totally duped as a medical community, as an institution, right? So we know what Sackler did, we know what Purdue did, it's totally evil. We know that they petitioned Congress to make the 5th vital sign. We know that that was tied to CMS payments, and then CMS payments said, okay, we tied your Press Ganey's performance of pain to how much money we pay you, and oh my gosh, OxyContin sales soared. Genius, but evil genius. We now know that. So let's start, now you can unknow that. So.
Is there an AI algorithm to help us?
Oh, yeah, that's a great. How do you measure pain or suffering or emotions? So there is a lot of work going on in that space. Again, if you go back to the review, you will find that people are using either the facial recognition technology to ascertain that. They are using a lot of different methods to ascertain that from EHR too. Because yes, pain was leveraged as something for certain benefits or not. I'm not going to get into that. But there is suffering and pain after surgery, right? You still have to treat that. And when you say it's a pain scale of 0 to 10, and you ask patient, what it is, it's just so variable, it's so subjective. So that's why there is a lot of work going on in either the facial expression ML algorithms, or even voice conversation, sentiment analysis. There's a lot of, and we are doing some of that work for sentiment analysis to discover that.
One last question. Last question. Okay, I'm Kate Stevenson. I'm actually doing a workshop late tomorrow afternoon. If you guys have more questions about doctors and becoming innovators, definitely come. The first third of the workshop is me talking about what does it mean to be a doctor, what does it mean to be an inventor, and where do you end up landing yourself, all before you start designing medical products. Good question. Second note, 30 years ago, engineers, I'm an engineer, started asking doctors what they actually thought about the stuff we were inventing. It's only now that we're starting to realize that maybe the doctors would like to know some of what we're doing. And so I think there's just not that level of curriculum yet, where we're starting to go, okay, how do we actually teach doctors about entrepreneurship, design, invention in a way that works with your lifestyle and your needs? So the last question I had was actually for Elizabeth, because I know if there's a more conservative group than medicine, it's government.
Yes.
And so tying into the theme of AI, did you guys leverage AI algorithms when you were starting to look at landscape and land use to correlate with health outcomes?
So no, that's So government is even less innovative than medicine, which I would concur with for the most part. And how did we use AI to look at landscapes and trying to do some of that work? So the answer is that was not part of what we were doing. I mean, we actually funded some AI work, but it was actually in the precision health and medicine space. So it was in neuroradiology. There is work that's happening now in terms of using AI and algorithms, actually that I'm working on in the opioid space. But it's also health. It's a tool that we have. It's Health 360, which is starting to pull in a social determinant of health data. And so we actually are starting to be able to do predictive analytics and look at risk. And what we're doing in the opioid space is doing care management. So can we actually have better outcomes by looking at risk, classifying, and then doing management? I think the next frontier is starting to do more of that in the built environment space and thinking about the nexus around health and outcomes.
And just to add to that, so actually the governments that are most receptive to AI are not the US government. So the NHS in the UK we're working with them. I'll talk about the company I have this afternoon, but basically precision prevention for an entire population. Single payer health systems are on the hook, right, for all of these costs. And if you can get fewer adverse outcomes using preventive medicine, it's an incredible savings for them. And so they're actually interested in using AI type techniques to optimize treatments for their populations. Now, there are early adopters amongst the government health systems, just like there are for everything else. So that's kind of the process.
Yeah, and I would say some of the work that for developing the tool was actually from other state governments. It wasn't necessarily the California government that did that, but I can't mention them just because of proprietary reasons. It's not public, but there are governments, and I think again, I think it's across the board when you're doing this, is you find folks who are able to think outside of the box. Even what we did within California, even though that wasn't an AI piece, was there were early innovators even within city and local governments that were willing to take some of those risks and have those conversations and step outside the lines and try something new. So I think that's probably just good advice in terms of partnerships and who you're working with.
You know, when I think about government's job is like policy and funding, right? So that's what's going on across different governments, not just US, but Canada, China, other places and all. And there is a lot of policy work and funding, whether it's UK, and that's where the support comes from. So the governments are not necessarily going to dictate those pathways, but when you look at the policy framework and the funding, there is a lot of work in that space, and there is a lot of effective technology that is coming out of that.
Thank you so much, all of